be starting the ASRS session now. We have been handed over the hall a bit late, so I think that's the unfortunate situation, but let's see how we can make it a bit interesting to the attendees. So we'll first start. I can
start with Dr. Hemant Murthy speaking on vitreous cases, the hidden danger.
Yeah, good evening. So I would be speaking on vitreoscheisis, an unseen danger. Now, we all know the ठीक है? ठीक है? Okay. So we know that vitreoscheisis is a lamellar separation of the posterior vitreous cortex, and it's the hidden danger, especially in conditions like high myopia, diabetic vitreous hemorrhage, and traction retinal detachment. Rarely, it is also seen in rhegmatogenous retinal detachment. Now, we assume that rhegmatogenous retinal detachment will have a PVD, that's why they develop the detachment, but you'd be surprised that it is present even in that. This is a video of a patient who had vitreous hemorrhage, and after clearing the hemorrhage, you see everything looks fine, and just looks at a step of laser, but then when I stain it with triamcinolone, you see the posterior cortex remnant present. So you know that there has been vitreoscheisis, and if this was left, this would be a scaffold for proliferation and recurrent hemorrhage. So in all patients of vitreous hemorrhage, always try to stain it with triamcinolone. You would come across situations wherein patients have this posterior hyaloid still present. So this was one of the first cases wherein we started observing that this is very frequent, especially in diabetics. So you see the entire posterior cortical remnants being present. And this is at the end of surgery when everything is clear. So we need to recognize, because if we do not remove these cortical remnants, then this would be the scaffold for recurrent hemorrhage. And in retinal detachment, it's a frequent cause of PVR. In high myopia with macular hole detachment, this is also one of the reasons why there is failure of settling the retina. This is a patient of a traction retinal detachment. After removing the tractional proliferation, when I stain it with triamcinolone, you see that the macula has all these cortical remnants. Now, this needs to be removed. We would assume that most of this remnant would be in the posterior pole. No, it's also present in the periphery. Here you can see that I'm removing all the remnants even at the periphery. So if this was left, we know that what would be the problem. Why we see patients with recurrent hemorrhage is one of the reasons is because of this presence of vitreoscheisis. So if you remove this cortical remnant, you would probably have a much better chance in seeing that you don't get hemorrhage. In high myopia, it's very frequent. So probably in every case of high myopia, you would see this. So here I've just removed the posterior cortex at the macula. Now we know that at the macula, when you remove the ILM, obviously you'll remove it. But this is not so much as for the macula, but for the periphery, which I will come to. In this video, you will see it. So when you stain, you would see that the periphery has all the cortical layer. The posterior layer is still present. And once you stain it, you would be surprised that all of them have it. So, and you need to go to the periphery. If this is not removed, obviously this would be one reason why retina would fail to attach, because this would contract then and cause a redetachment. So we need to remove this meticulously. I think yesterday in one of the subspecialties, all of that was alluded to, that, even the Egyptian surgeons were mentioning that they stain it again and again, even in diabetics, because that's where they see it a lot more frequently. So here you need to stain it, and once we remove this, we even stain the inferior retina, you would see that it is present. So you have to probably stain, restain, and then remove all these. So this would be one reason why you would have to do it in all these surgeries to make it actually see that you get a good success. Now this is a patient in which there's a rhegmatogenous retinal detachment, and I started the surgery, I felt, yeah, there is a PVD, but in all these patients, I also stain it again with triamcinolone, and you can see that there is a lot of vitreous still present. So these are all causes of proliferation. So one has to be very careful, and you need to see that we clear this before we So this is where you can make out how it is important even in rhegmatogenous detachment. Now, one of the ways that you can do it also is use the Finis loop. This is a patient of PDR with vitreous hemorrhage, and I've used the Finis loop to initially scrape off this posterior cortical remnants at the macula, and then I use the cutter. Basically, the cutter, because they are so fine these days, one can actually induce the separation of the posterior hyaloid fairly well. And you can, once you get the edge, then it's very easy to do this. Once I have this edge, then one can go forward and you can actually remove it fairly well. So these are a lot of examples which I've shown you just to show you that it's possible to, one second, we go back. And there has been number of studies which have looked into the role of vitreoschissus, and they found that in a study by Van Overdam, he actually did the histopathology study, and he found that vitreoschissus induced cortical remnants was one of the causes of PVR. Similarly, there are various other studies on both diabetics and myopia. So in conclusion, I can say vitreoschissus is seen in a number of retinal conditions, and I think recognition is what is important, as it would prevent failure of your surgery and complications. Thank you.
Dr. Murthy, but do you feel that sometimes you have created breaks in your effort to remove the schisis? Have you created retinal breaks?
No, not at all, not at all. I don't think I've ever, because nowadays the cutters are so precise that you can actually take it out without a problem. I initially felt it's difficult, but I used to use the soft tip cannula so that I don't injure the retina. But then these cutters are marvelous. Actually, once you go finer, that is 25 and 27, you really don't feel the need of using the soft tip cannula.
And sir, do you also try to remove the ILM in these cases, or no, it's not necessary?
I do ILM in the posterior pole. That's what, so I mentioned, we generally remove the ILM. So we are sure that we remove everything. Yes. But in the periphery is where the problem lies, which we never, a lot of times it gets missed. Yes. So this is just to, make it aware that there is always a problem like this.
So many times this bevel cutter, we can go very close to the surface and able to lift this.
Yeah, it's very easy. I feel it's, yes, once you get the hang of it, you just need to have low suction, and it does work very well. Actually.
Sure, sir. Thank you. Thank you very much, sir, for a wonderful presentation.
Even the brilliant blue-green dye can sometimes stain the vitreous.
Can do
but
that.
sometimes it doesn't, and then you have to use...
The triamcinolone is a little better in all this, actually. Thank you.
Thank you so much.
Very good videos. Now we'd invite Dr. Dharmesh Kar to speak on PDR vitrectomy. Yeah, you have a taxi waiting for you?
No, there's a person here.
So good afternoon, everyone, and I would like to thank AIOS and ASRS for giving opportunity to present at this session. And I would like to talk today on PDR vitrectomies, and my financial disclosure is none. Now, PDR vitrectomy is a challenging and need a customized approach. It need to keep all the armamentarium ready. We need to do it very patiently and slowly. Aim is to prevent the iatrogenic retinal breaks or intraoperative bleeding. So usually we do on a first case of our OR day, or when we are not in a rush. That will be the case we are doing. It can become lengthy anytime. So for consideration for the surgery in the PDR, we divide 3 ways: preoperatively, intraoperative, and postoperative preparation. Preoperatively, the patient selection is very important. Expectation of the patients, we have to explain all the pros and cons. Many times after good anatomical success, still they don't have a good physiological vision. The types of diabetes in type 1 and younger patient will do early treatment. The use of anti-VEGF is very important. It's always helpful for the better dissection and bloodless surgery. Prefer to give 48 hours prior to the surgery. And we have to give after the physician fitness that once we inject, then we should not postpone or cancel the surgery, because it can give an increased tractional. So once everything is finalized, dates are fixed, then we give anti-VEGF to this patient prior to surgery. Intraoperatively, the main aim is to maintaining the hemostasis. It's a very important, because all the bloodless surgeries, the better outcome as it is for the membrane dissection. The IOP control, temporary IOP control, all vitrectomy machine, just raise IOP for few seconds, we can control the bleeding. Endodiathermy, I usually prefer endodiathermy of 27 gauge. Even in 25 gauge surgery, the 27 gauge endodiathermy is very fine. We can find each small stalk of the bleeder, and we can just do very controlled proportional diathermy. So surrounding tissue will not get damaged, especially in the around the arcade and macular areas. We can do the endolasers. Tip of the cutter, just the tip of cutter, we can just bluntly press for a few seconds and stop the bleeding. And control of systemic blood pressure during the surgery help to reduce the bleeding. Intraoperatively, the aim is to relieve the traction. So we do the careful dissection, segmentation, delamination, outside in vitrectomy. So the way the method we are doing with the newer vitrectomies, which help by cutter only, we will able to do all these steps. Tractional retinal detachment, combined RD or a tabletop RDs. The tabletop RDs are one of the most challenging cases in the PDR surgeries. Use of triamcinolone, sir has shown just now the excellent videos. I use each and every case of PDR, and I recommend that triamcinolone should be injected for the anterior hyaloid, for the remaining vitreous section near the vitreous base, and for the hyaloid separation or the any remnant which is given tractional. ERM pilling and ILM pilling also important. Multiple techniques are used in the PDR surgeries: bimanual, bevel cutter only surgery, viscodissection, proportional reflex surgery. Gas versus oils. It's always an intraoperative decision to put the gas versus oil. Gas is preferred, but sometimes it's unavoidable, and we have to inject the oil. Post-operative close monitoring of such patient is very important. Better systemic control of diabetes and hypertension post-operatively. And if silicone oil was used, consider it for the short term, and early SOR we are doing in these patients. All armamentarium should be ready when we are planning PDR surgeries. Keep a chandelier light, finesse loop, and graphic forces, beveled cutters, and bent MVR blade. So I use the new MVR blade. We just bent a tip, and that MVR blade can be used and helpful for the very finer dissection of the membranes. Now this is the photograph we'll show. This is the 25 gauge bevel cutter. The port is so 47% closure, and we can go very close to the retinal surface. And this can help to dissect or just separate membrane, especially when there is a tabletop RD and there is a retinal fold. There is a high chance that we will not create a retinal break. And the only cutter with the low suction can help us to dissect the things. Now, bimanual versus unimanual is always the challenging. We can start with unimanual. At any time, we can convert to a bimanual. With the newer cutters, it is always, sometimes we are able to finish the surgery unimanually. Now, combined phaco plus vitrectomy. Now, there is both the two school of thought. Some people prefer to do combined phaco-vitrectomy. Some people want a pseudophakic eye. Pseudophakic eye for diabetic vitrectomy is the best because 1 or 2 days, 2 weeks before someone has done phaco, then we will able to remove the anterior vitreous very clearly. We can stain with triamcinolone. We prevent the anterior hyaloid proliferation and recurrent vitreous hemorrhage post-operatively. Combined phaco-vitrectomy, the cons are if we put the lens same time, sometimes gas is injected, there is some recurrent bleeding. So still there is a pros and cons for both. But if patient is from far, not able to travel, not able to come frequently, then combined surgery is preferable. So this is the surgery where we have only used the cutter. .25 gauge bevel cutter was used, and we able to separate the central tractional blend from the peripheral vitreous. Now here the most part is all this tractional band has the retinal folds underneath. And triamcinolone will help us to identify the exact plane of dissection. And now top of the membrane vitrectomy is very helpful with the 25 and 27 gauge cutter. So sometimes wherever the membrane is very stuckly adherent and not able to separate, we just keep the cutter and the port is so close that we will able to control and trim out the remaining membrane and separate it out. And once we get a good plane, we'll able to lift up whole membrane. We have to be patient till the last end of the tractional band pieces. If we are just in hurry, we can create retinal breaks. At the end, we have done ILM peeling for this patient, and as there was a retinal bands, so we have put the silicone oil for, and oil was removed after the 2 months. Now, this is one more surgery where we have separated the tabletop membrane from the surrounding, and then we have shifted it to the bimanual surgery. We have put the chandelier lights. And with the close scissors, we will just able to dissect the membrane from retina. And while dissecting, we can just take care that minimal traction should be there on retinal tissue. And if there is a bridging tissues between the two adhesion, we can cut with the cutter and separately manage each membrane. And the laser was done. Now this is another very adherent membrane. So we have used the forceps. and then changing it to the bimanual surgery after separating the membrane from the surrounding part. Sometimes the small stalks are usually a bleeder, so we take care, we slowly dissect and in the next case, in the beginning, we started with the back tractional RD. So the membrane was separated bimanually. The ILM peeling was done after the staining. And there was a PFCL used. There is a subretinal bands and subretinal gliotic tissue. And this was removed with the help of cutter itself. So if we not take care of this, it can give lead to recurrent retinal detachment and this. So the newer cutters are very helpful as a multifunctional tool in all these cases. So the gift of service, the best thing we can give it to the all PDR patient and the smiling faces we see. If many time it is, even the visual prognosis is not good, better to try it and give, at least they get ambulatory vision. It is better to try and do a good PDR surgery. Thank you, everybody.
Thank you, Dr. Dharmesh. Very nice. I think you've, you've shown all the advantages of the newer instrumentation. Although we have the finer gauge cutters, beveled cutters, but there is always a role of bimanual, which you have we want that to be stressed, that bimanual surgery has its role in current day surgery in spite of whatever instrumentation we have. So there are a lot of situations wherein bimanual makes it safer for the patients without seeing that there are iatrogenic tears. So I think it's always safer to do it.
So it's anyway we can start with unimanual, and wherever we feel we can, by just filling the traction, we can shift or change it to the bimanual.
So we should always be open for multiple
Bimanual,
techniques.
always. So we keep all our armamentarium ready for PDR, always.
Perfect.
Other thing is not to be too enthusiastic with raising the IOP. We may end up with an ischemic disc and not know why vision is poor. Third is when we are doing a fluid air exchange, again sometimes we are very enthusiastic to dry the surface and we keep touching the optic nerve head with the flute tip. So that damages the nerve fibers, and so again the visual outcome is very poor. So always we should try to limit ourselves to a cushion of fluid over the optic nerve head rather than hitting the nerve itself.
Sure. Very nicely, madam. So usually I do PDR vitrectomy in a lower IOPs. So we do the standard 30 IOP setting, I do at 20-25 IOP.
Yeah, we should
And even if we raise it to the CT, it's just for fraction of seconds to just stop the bleeders, but we keep a watch on pulsation or anything if changes or not. And better not to touch the optic nerve, or even keeping some thin film of fluid in diabetic will be, it's okay. Yeah.
True. Good. Very good videos.
Sure, thank you very much.
Thank you. So now we move on, and the next speaker is Dr. Vishal Agarwal, who is a prolific surgeon from Jaipur. So he'll be speaking on pediatric retina.
Thank you, ASRS, for giving me this talk, and I'll be speaking on vitrectomy in pediatric retinal detachments. As we all know, pediatric RDs account for less than 10% of all cases, and these are most related to trauma, syndromes, and congenital anomalies, unlike adult rhegmatogenous detachments. And traditionally and even now, scleral buckling is the gold standard, and I would also prefer buckling as the first line management in all pediatric RDs. But there are many cases with varied anatomy and very late presentation, especially in children, and altered vitreoretinal additions, deem many of such cases unsuitable for scleral buckling. So I'll be in the next course of 10 minutes talking about vitrectomy and detachments other than ROP, of course, because that's a different presentation altogether. So evaluation is very important. Systemic workup, evaluation under anesthesia and other screening is very important. These detachments are associated with familial conditions, so sibling screening, FFA and prophylactic lasers, especially in conditions like FEVR, is very important. And of course, a thorough pre-operative counseling explaining all the risk and benefit to the parents has to be done. So coming to the surgical part, so there are many points to be considered. A thorough planning has to be done, whether you want to or not to want to put an encerclage. I always routinely put an encerclage in pediatric detachments, unlike in adult RDs where I do not. Lens management, of course, not a cosmetic surgery. If the lens is coming in between, you have to do a lensectomy. PVD induction is a major hindrance, and you should have a set technique to induce the hyaloid from the retina using of dye. Sometimes these cases require the large retinectomy, ILM peeling, and the choice of tamponade. So coming to the first part, that is PVD induction. So for the past many years, we have been using a simple and a very reproducible technique. We do a core vitrectomy and stain the vitreous with the triamcinolone acetonide and put a small amount of PFCL bubble at the posterior pole. And with the end gripping forceps, we try to make a hole in that hyaloid, which is very easy. It's just like peeling a membrane. And once that well or small hole is made, you just enlarge it a little bit and put more PFCL in that, and it generally atraumatically cleaves that hyaloid from the retina and till the equator, inducing the PVD. And from that point onwards, you can do it with the cutter. And there are many benefits, very atraumatic to the retina. And like in this case, there was a small bleed, and it automatically gets tamponated by the PFCL overlying it. So this works almost in every case of pediatric detachments. This is a wide-angle view of the same technique. You can use the forceps, or you can use a blunt dissector like the light pipe. And once you have made an adequate hole, you just have to sweep the other part, the other direction with the light pipe, like I'm doing here, gently, and the whole bubble goes inside. You refill it with PFCL, and you induce the PVD till the equator, and it works well. Coming to the common cases associated with pediatric detachments, of course, traumatic is the most common, and dialysis, of course, the first choice again is scleral buckling, but there are some cases where there is old dialysis, large dialysis with everted edges where scleral buckling will not work, although you have to augment the encerclage, with the encerclage. Thorough base dissection and freshening up the edges of the dialysis is what usually works here, and there can be no compromise in the time you give to the peripheral dissection in these cases. So one thing I would like to point here is these are anterior pathologies, and you have to be very careful. Like in this case, the cannula was kinked, and all the fluid was going through the large dialysis into the subretinal space, and there was practically no place to work on. And we realized it in due course, and we did not proceed with the surgery and shifted the cannula to the inferior nasal quadrant, and now you can see. And this is a quite old video, and the retina then settled. So you have to keep in mind about the fluid direction in cases you're operating the anterior pathology. Stickler syndrome. So we were working in a tertiary care center where a lot of referral Stickler syndromes were coming with GRTs. And the point here is it's optically empty vitreous. So a fresh GRT will also curl and adhere to the other part of the retina, and you just cannot unroll the retina with the PFCL here. And if you forcefully do it, it will go into the subretinal space. So this is only a 7-day GRT and seemingly fresh-looking GRT, and you can see the rolled-up edges and the fibrosis, and it could not be unrolled with the PFCL. So you had to use the brush and the forceps to unroll it and trim the edges. So you can either do a oil exchange or a air exchange and then laser. So, and the other thing here in Stickler syndrome is that you have to examine the periphery very well, and even if there is a detachment, you have repaired that, and the other area is a retina on area. If you see an indent, in many cases you'll find these seemingly sieve-like lattices, and if you do vitrectomy over, they'll just open up. So you have to keep in mind to do a thorough 360-degree base indentation and check for all these, lesions in the periphery, in the attached retina also. The third video of the Stickler is because there are radial lattices and you can get GRTs with the radial rips here, and the whole surgery is as you do a routine GRT, but the important thing here to remember is that the radial rips are very prone. These areas are very prone where the PFCL might go into subretinal space. You have to be very careful in these areas especially, otherwise it's not much of a different surgery than the other GRT surgeries. Coloboma RDs are difficult surgeries because the attachment to the hyaloid at the edge of the retina and the coloboma is very difficult to detach. So there are multiple techniques you can do to achieve that. Again, we use the same technique as I described in the first few slides, making a hyaloid cleavage plane and injecting PFCL. And this works very well in these cases also. As you can see, the whole hyaloid layer has been detached, and you just need a gentle nudge from the cutter to detach it from the colobomatous area. Coming to FEVR cases, this was my first case of FEVR, which I did almost 10 years back, and I did not know the complexities of these, of these cases. And you can see this temporal fibrovascular area, and I thought I would, peel it, but that was a very, good learning lesson to me, because this is so adherent that if you try to peel it, you will create bleeding, you will create inadvertent iatrogenic breaks, and there is no point you can peel it. The only thing you can do is to just shave it off. So after 6 or 7 years, this boy, 18-year-old male, developed RD in the second eye of his, and this was apparently very well lasered. And here, I had learned my lessons, so I did not try to peel much the temporal fibrovascular area, just peeled the interior and the posterior edges. But there are anomalous additions to the posterior pole also. As you can see, as I was inducing gently, the PVD iatrogenic macular hole formed. So you have to be very gentle and very slow in these cases, because you don't know multiple attachments are there, and they might create complications. You can see the laser barrage in this case, which I had done around 10 years back, and still there was a break which formed at the edge of the CRA and caused a RD. For the macular hole, of course, you do the routine thing. We did the routine inverted ILM peeling, which I do under PFCL, and the patient did fine in the post-op period. A thorough base indentation and a thorough laser anterior and posterior to that fibrovascular band which you can see. So these were relatively fresh RDs secondary to FEVR. This was, you can see as it looks, a very old detachment with demarcation lines and pigment dispersion. And these are difficult cases, and you don't get that PVD hyaloid thing I was talking about in the PFCL. The only way here is you have to be patient and give time and continuously, grasping and re-grasping the hyaloid layer and inducing a PVD. And there is no other alternative to that. There is no technique defined in the book to do a seamless PVD induction in these cases. But it will go off if you do keep on trying and keeping in mind not to injure the underlying retina. And the patient did well, and this is the post-op photograph under the oil, 3 weeks post-op. This was a 10-year-old boy, had undergone a skeletal buckling, was doing fine for 1 year, again developed RD, oculocutaneous albinism, and we could not find the primary break. So this is what we did. We created a retinotomy, injected PFCL at the posterior pole, and injected some subretinal trypan blue. And with the Brownian movement, you can see that it's coming out through the break. Because it is so less contrast, it's impossible to find the causative break in some cases. And we could find here, and then, laser barrage and cry out that break. The patient did fine in the post-op period. No matter how careful you are and meticulous you are, there will be redetachments in these cases, and you have to go inside early. And in these cases, I have found that the trypan blue dye is very helpful in, delineating all the epiretinal membranes and the remnant fibrotic layers. Here you can see the whole membrane which had led to the PVR and dairy detachment comes out in one go with end gripping forceps. And of course, after you peel that, you of course have to do ILM peeling in this case to reduce the incidence of macular pucker. So as I was saying in the initial slide, these are not cosmetic surgeries, and if there is a lot of anterior PVR, you have to sacrifice the lens. You of course avoid in most of the cases, but not at the cost of settling the retina. So here we peeled the retina, removed all the membranes, but could not settle and relieve the traction. So a relaxing retinotomy was done, and the thing about relaxing retinotomy is that it cannot be a small RR, it cannot be a modest RR. You have to do a large RR to settle the retina and adequately relieve the traction. So the last cases, of course, these some are traumatic RDs are associated with the macular hole, and this one was a very large macular hole. And this is the technique we usually do. We peel the ILM in a broad-based fashion and under the PFCL, and you see that we are fashioning the flaps very near the arcade and turning them over the hole. You don't need to stuff them into the hole, but on the PFCL, they stick well inside the hole. The patient did fine, anatomically at least, in the post-op period. So to conclude, vitrectomy in children because, for RD is challenging because of the unique anatomy, and if performed meticulously, taking care of the anatomy, can yield excellent results. Of course, it's not a perfect science, and there is no standardized treatment. Every case has to be managed in a customized way. And the final thing is visual gain remains suboptimal in many of these cases because of the late presentation and possible irreversible photoreceptor damage, and that has to be conveyed to the parents. Thank you so much.
Thank you, Vishal, for this wonderful presentation and excellent videos. And very nicely shown all the complicated surgeries managed well. We'll invite Dr. Mallika Goyal, Madam, to speak on fibrin glue in the management of complex retinal detachment.
Excellent videos, Dr. Vishal. Excellent videos. Okay, so I'll be speaking on something new that I have done, not even new, 2 years back I started it. Fibrin glue to close retinal breaks in complex retinal detachments where silicone oil has been left for tamponade. So I have used only the Baxter glue. Now, glue-assisted retinopexy for simple rhegmatogenous detachments has been described previously, including by Dr. Mudit Tyagi, but that was done to obviate or reduce the need for tamponade. It has not been reported for complex retinal detachments where silicone oil is also left in situ. So about 2 years back, we had a patient with combined fractional rhegmatogenous detachment secondary to PDR. The surgery was not successful because there was an open break with some membranes superior to macula. So this time we went in second time there was oil in the eye. We did additional membrane peeling and then used fibrin glue for the open break. And to our surprise really, there was a rapid retinal reattachment with minimal post-operative positioning required. And this was the 8 months follow-up of the same patient. Vision has improved, retina is attached, pressure was normal, there was no inflammation, the oil had not emulsified earlier than expected, and the glue was not seen at all. So encouraged by this, we have used it subsequently for other PDR cases where there is bleeding during the membrane peeling and the blood cannot be dislodged from the retina. The retinal breaks cannot be lasered because of this blood, but we know where the breaks are. So after attempting laser and drying the surface during fluid air exchange, subsequently the two components of the glue are instilled over the retinal breaks, the two retinal breaks. The surface has to be dry, and you can see the glue post-operatively in the first week, but it's not seen by the third week, and the retina is nicely attached with no complications. So again, a PDR detachment, two retinal breaks with some bleeding. The two components of the glue are instilled sequentially over each break. wherever laser is not adequately possible. Where it is possible, there is no use. This is another case where the break is very close to the foveal center. So after fluid air exchange, here we injected the less viscous component first. So there is a large pool created, and then we injected the more viscous. This was an error. You can see that the glue is plugging the hole, and it's not even seen by the 6th postoperative day, but the retina is attached. So then we extended the indication to other retinal detachments such as macular hole RD in high myopia, where ILM peeling is not possible or it's a failed macular hole RD, like this patient. So we used it to close the macular hole at the end of fluid air exchange with very good attachment. This was otherwise a failed RD. Similarly, a young boy with a very old retinal detachment, but the macular hole was the only break. So here again, after fluid air exchange, the hole was plugged by the fibrin glue, and the glue is already not seen by the 10th postoperative day, but it is plugging the hole is closed, retina is attached. This is another patient where the retinal detachment settled, but the macular hole did not close. However, this is still success because retinal detachment is a more serious condition than macular hole. So the things we learned along the way is that the two components should be drawn separately in two different 2 ml syringes, not 1 ml syringes, because those are longer, so more difficult to maneuver. And inject the more viscous sealer protein first, which is the blue top. So you can remember it as blue first because the less viscous fibrin spills and causes a large collection. So use this first, more viscous first and then the second one, so that it clots immediately on contact and there is a smaller coagulum. Check for needle tip blockage immediately before we enter through the sclerotomy because blockage is very common with this glue, and attempts to overcome the block close to the retinal surface causes the liquid to eject with very high force, which can enlarge the retinal break and also cause excess collection. And avoid excess injection. This is the most common problem actually because just 1 or 2 drops of each component is enough. However, this is very difficult because this is transparent, and even after the 2 components come in contact, the glue remains transparent for some time. So the surgeon is not clearly visualizing the injected amount. So there is a tendency to over-inject, which has problems. Now when it is injected at the macular hole or near the macular hole, there needs to be caution because we captured one patient where you can see the glue gone subretinally from the hole near the macula, and then within few days you can see an atrophic track there. So if this happens in the perifoveal area, you would have a visual deterioration. So it should not be avoided for the routine closure of macular holes. Now also if you inject excessive amount in a peripheral break, it can collect like a large lump under the retina and cause the break to remain open, which is counterproductive, as we happened in this patient. Subretinal glue and the break was open. So we had to reoperate, do some membrane peeling, and then reattached the retina. So in conclusion, fibrin glue can be a useful adjunct in the management of complex retinal detachments when laser for retinal breaks is not possible due to bleed, edema, or proximity of break to macular center. Glue is not seen as early as 1 to 4 weeks after surgery. No adverse effect with silicone oil in situ, no inflammation, IOP rise, or oil emulsification in the 20 months follow-up. There is a rapid retinal reattachment, and very importantly, the patient does not need post-operative prone positioning because the break is already closed with the glue and is not dependent on the oil tamponade or the gas tamponade to keep the face down. Avoid routine use for macular holes as it can cause retinal atrophy in some cases when it migrates subretinally through the break. And avoid excess injection as it can keep the break open even in peripheral breaks. Thank you.
Sure. Yeah. Thank you, ma'am, for the excellent presentation. Now I'll request Dr. Taraz to speak on refractory macular hole, amniotic membrane graft and autografts.
Michael. So I'd like to thank AIOS and ASRS for this opportunity. So let me start why it all began. We were always curious to use the human amniotic membrane or the HAM in challenging macular hole cases. I tried it a couple of times but found it very difficult to handle. So what were the problems faced? Number one, visualization. It's translucent and thin. It's difficult to visualize extraocularly, and even intraocularly in high myopes. So you can lose the graft because it's translucent and difficult to see. Sizing. So we tried to size it using Vanna's forceps initially. Then we tried sizing in the eye using the curved scissors. I found it very messy and non-elegant. So the optimal size was a challenge. Third was placement. So chorion side, which is supposed to go down, is very sticky. So we found it used to keep on sticking to the forceps. And then you're trying to remove it from the other forceps, it gets stuck there. So then it becomes like a very messy kind of a maneuver in the vitreous cavity. So this was the reason why we were not using it much. And the other thing is shoving it into the hole also. I thought that if you are pushing it with sharp forceps, you're going to cause a lot of RP damage. So we discussed this with my friend Dr. Dilraj, who was one of the pioneers of the neurosensory graft, and we planned a workaround for each step. So there's a fun video which we've made, which I'll share it with you, so you can enjoy the video. And it's a little humorous also, so something to wake you all up. You can start a video, audio is there. Audio.
Surgical toolkit for ham grafting in VR surgery. Dr. Rizzo's group recently described the brilliant concept of human amniotic membrane or ham grafting for recurrent macular holes. However, there's hesitancy in adopting this technique due to difficulty in visualizing, handling, and placing the graft.
Hi guys, hope you're well. So I am going to hold your hand through preparing, making and roasting the most amazing Christmas roast ham.
Let us guide you through our recipe for ham in VR surgery. We depict a surgical toolkit using 3 S's: staining, sizing, and sliding. First S, staining. It is true that the amniotic membrane is indeed difficult to see. It is white, translucent, and thin. Simply staining it with a few drops of brilliant blue dye solves the problem. Second S, sizing. We need to determine the graft size and then cut it neatly and accurately. We use inexpensive, disposable dermal trephines. We measure the macular hole indices preoperatively on OCT B scan. After some trial and error, we found that the optimal graft size is roughly the average of the sum of the minimum linear diameter and the base diameter. See how easy it is to get the perfectly sized graft with a dermal trephine. Third S, sliding. Accurately and atraumatically placing the ham graft is a major challenge. We use a bimanual sliding technique with a Tano brush and a nitinol flexible loop. Let's see a few cases. This 62-year-old lady presented with failed macular hole surgery done 2 months ago. See how nicely the graft slides in with the bimanual technique using a Tano brush and a finesse loop. Post-operatively, the hole is closed. This RD case came post-operatively with an attached retina but had developed a macular hole and oil emulsification. We did a silicone oil removal and bimanually placed a ham graft into the macular hole. See how beautifully the hole has closed. This was a failed macular hole case who developed a total retinal detachment with vitreous hemorrhage. In such cases, we place the graft under PFO or after fluid air exchange. You can see how we bimanually slide and spread the graft and place it accurately under PFO. Post-operative OCT shows that the retina is attached and the macular hole is closed. This was a very high myope with a posterior pole retinal detachment and a macular hole. In this case, we slid in the ham after fluid air exchange. In such cases, we take the graft size to be twice the MLD. See how scary the pre-op OCT was and how nicely the retina is settled with a ham graft.
Look at this. I mean, luscious. There is no more festive sight than a glazed ham.
With the Triple S technique, we provide you with a toolkit and our recipe for the perfect ham graft in VR surgery.
So this was the amniotic membrane. Just a little bit about neurosensory graft. So if the hole is in detached retina and availability of ILM is an issue, this is where we sometimes use this technique. Just one case to elicit this. This is a patient who had vitrectomy with oil, developed a ERM, at that time had a ERM plus ILM peeling for the pucker. So the patient was referred to us with a recurrent RD. You can see the MH with RD. And this is the video. So this was the area where we are going to take the graft. I prefer to use scissors rather than the cutter because the scissors are more controlled. And then we cut it till we have a little bit still attached so that it doesn't fly off. And then the idea is to put a PFCL bubble which kind of covers this and then drag it under this over the macular hole. So I think this. So now position over the hole, and here the finesse loop is very gentle and I feel it's atraumatic. Then we do a fluided exchange and put the oil. And this was post-operative. You can see it looks pretty nice. Graft seems to be integrated and patient is from hand movement 6/60, retina is well attached. So my kind of a rough algorithm is if the ILM graft, I always prefer to use ILM and inverted ILM for primary cases. Never use any of these for primary cases. But if the hole is small, less than 1,000 micron, I mean, this is what we define as small right now. So we do a ILM graft technique. I do a neurosensory retina for macular holes with RD, which minimal PVR or no PVR. But I use an amniotic for large failed macular holes with attached retina because I don't want to really cut the retina when it's attached. So I prefer the AMG. Pediatrics, I don't want to cut retina unnecessarily, or very complicated high myopes sometimes because we don't want a very long the case to go on too long because of risk of choroidals and the challenge in these long eyes. Thank you.
Thank you, Dharaj, for the excellent presentation and very nice video. Yeah, thank you. Any question from the audience?
What was the instrument that you used to slide the amniotic membrane graft inside the eye?
So I use a bimanual technique. I don't know why. You can use 2 Tanos or 2 finesse, but I like to use in the right hand a finesse loop and left hand Tano brush. I think that works very well because with the left hand you kind of anchor it, so you need something firmer. So I find the Tano is firmer, and the finesse, it's more flexible. So that helps you tuck it in. So because I'm right-handed, so I suppose if you're left-handed you can reverse it.
No, she's asking how do you insert it inside the eye?
To take it inside is not
Yes,
regular forceps, any
the
intravitreal
forceps.
forceps. But once you take it inside and rest it on the retina, then I don't like to push it in using forceps. I like to slide it in with these instruments.
So you use the ILM peeling forceps and grasping to take it
Yeah,
inside?
regular.
Regular
ILM peeling
ILM
forceps
peeling.
or whatever, end gripping,
But you
whatever
don't
you have it
prefer to
handy.
slide it under the PFCL bubble. You don't insert PFCL in these cases,
No,
unlike
no,
the
no.
retinal autograft.
No, in retina autograft, we put PFCL. In the AMG, no PFCL.
Why?
Under
Does it
cell eye.
make it more slippery or why?
You don't need it.
You don't
You
need
don't need it.
It does not slip off.
It doesn't, it doesn't slip off, and always I have to underlay. I've done overlay in few cases. I was became very bold, in surgery. Sometimes you say, oh wow, it's not chora, and then the next case, you have a failure. So now I don't do. I just do underlay.
Thank you.
Do you find that the graft has moved, dislodged during your fluid air exchange, and do you think a visco would have kept it in place or a PFCL would have?
So that's a very good question because I had one patient where even underlay dislodged. So in that case, you can put visco on top, and then one patient I put autologous blood because I think Dr. Meena Chakravarti has described this technique for macular holes where she in Retina journal some years ago. So I just put a drop of blood on top, and I feel if you're finding when you're doing fluid exchange, if it's rolling or moving, then you can do any of these. It's a very good idea.
Autologous blood takes time for them to prepare, so we have to tell them before the surgery that we might
I
need
just
it.
I asked the anesthetist to take out the blood fresh. Then they take out the plunger of the needle. The sister takes it out in 1 ml, and then I just put the fresh blood on top. I don't do the fibrin and that.
Okay,
Yeah, I think it works fine.
okay. Great.
Okay.
Any other questions from the audience?
So we will conclude this session, and we'll thanks all the speakers and ASRS and AIOC for this opportunity. Thank you, ma'am.
Thank you,
Gaurav.
thank you everyone.
Thank you, Vishal.
Thanks, Dr.
Thank
Vishal.
you.